Good afternoon. We're going to start. Um, so, some of you already know, or all of you may know, that we're going to start using that CT perfusion software called Rapid, and some of our stroke protocols are going to change and are going to include that, hopefully starting tomorrow. So I was just waiting to do this so you guys were familiar with what we're doing and you can start doing it every time a stroke is called. But I'm going to review the whole thing, the whole imaging of acute ischemic stroke, starting from when the patient gets to the ED, what you guys need to be looking out for before the TPA or before thrombectomy and stuff like that, and why you're looking out for that. So we're going to review the CT, the CTA, the CT perfusion, and at the end we're just going to touch briefly on the MR perfusion, which is just going to be done for certain cases and never or almost never in the acute setting. So this is our stroke protocols. For those who are not familiar with those, we divided our stroke patients into 3 different groups. The Dr. Stroke A is that group that is eligible for TPA administration. So it's every single patient that has a last known well less than 4.5 hours, regardless of the severity of the stroke. Our Stroke Bs are those patients that we know are beyond the 4.5 hours. And if you notice here, it says up to 12 hours. And that's going to be extended to 24 hours. So that, with the time alone, after 4.5 hours, they're already out. They're not eligible for TPA. However, if the stroke is severe enough, then, and we do that by doing a clinical assessment called VAN, which assesses the vision, aphasia, and neglect. If they're VAN positive, then we proceed with our CT and CTA to assess for a large vessel occlusion. And then our last group is those patients with mild strokes. They don't have an NIH stroke scale more than 6, and they don't have a VAN positive, so they're very, very unlikely to have a large vessel occlusion. They're beyond the 4.5 hour window, which means they're not TPA candidates, and they're very unlikely to be thrombectomy candidates. So they're on that last group that will only get medical management. A and B are the ones that you guys get activated. C does not get activated until, neurology comes in, and then they may think it is severe when it was not severe at the beginning, or it was not picked up as severe, and then they get activated as B. So currently, for our strokes A's and B's, we do a CT and a CTA for every single stroke A and B, regardless of the severity, not for C's. And then when we get a transfer, you may know, sometimes I ask for something, sometimes I don't ask for a CT, sometimes I do ask for a CTA, et cetera, and that is based on this. If the patient has a known large vessel occlusion, so a CTA was done outside, and we were called and told this is a known LVO, but the last scan, by the time the patient was here, the last non-contrast scan was over 2 hours, then if it's under 2 hours, they just go straight to IR, so we don't do anything. If it's over 2 hours, then I get a new non-contrast CAT scan. And if the patient doesn't have a CTA, we just don't know if it's a large vessel occlusion or not, then we do the complete protocol. We do the CT and the CTA again, and then we assess. So that's why I sometimes go straight to IR, or I go to non-contrast CT or the CT CTA.
What are you specifically looking for on the CTAs done with a route after 2 hours? Like when you get the new CT without, you're looking for
I'm looking for the progression, the evolution of the stroke. Because, if they tell me, well, the CT scan is clear now, but the patient gets here 4 hours later, I don't know if the CT is already clear. And then most of those instances right now, we will be doing the CT perfusion, and that'll come at the end. These under 2 hours are mostly Willis-Knighton transfers. I have access to them. The scan was, the transfer doesn't take 2 hours from Willis-Knighton. Everywhere else it takes over 2 hours, most likely. And this is the pathway, and we get activated, and it's kind of busy, but yeah. So here the ED places the orders for the CT and the CTA, and we will be adding, this is our A, this is our B, and we will be adding that CTP over here on the B side. Okay, so first line treatment, IVTPA, approved in 1996, so over 20 years ago. And it was extended in 2012 for 4.5 hours, and it was validated this year in January in 2018 with no additional exclusions. There used to be additional exclusions from 3 to 4.5 hours, and then this year those additional exclusions went away, so it's the same for everyone from 0 to 4.5 hour window. It's very rapidly administered. Its greatest benefit in the first hour and a half after the onset, which means most of the patients don't get that benefit. We know the efficacy will decrease with time, and we know the efficacy decreases with a large amount of clot. So if a patient has a known distal MCA occlusion, like we're talking M2, M3, only about a third of them will get reperfused with TPA. When it's M1, only 1/5 of them will get reperfused. 10 to 15% when it's an ICA-T occlusion, just a quarter of the basilar arteries, and ICA-MCA. And when it's an ICA-T occlusion, which means it's the M1, A1, and the supraclinoid ICA, none of them get reperfused, as well as the cervical ICA, none of them will get reperfused. So that's the reason why we want to scan these patients early with a CTA and take the patient to IR even with the TPA hanging. So we don't wait for the TPA to work. There's a bunch of contraindications. In yellow, you can see the ones that have to do with age and time of onset. So immediately, if the patient has a more than 4.5 hour symptom onset or unknown onset, that patient is out, no matter what. That's an immediate contraindication. Pediatric patient or less than 18, also immediate contraindication. In orange, you can see the ones that are related to the imaging that you're going to be looking at. So subarachnoid hemorrhage, intracranial neoplasm, AVM, or aneurysm in case you do a CTA. If you don't do a CTA, then you're not going to know if there's one. Recent intracranial surgery, if you have any post-surgical changes in the scans, you should tell about them. And then in case you were involved in an arteriogram that was done 7 days prior, you have to know that an arteriogram is not a contraindication. So this is arterial puncture at a non-compressible site. So any arteriogram that you do from a radial artery or femoral artery or a venogram, all those are compressible sites. We just have to put an extra compression if it's within 7 days and go ahead and do the TPA. So that's not a contraindication. What would be a non-compressible site? Probably the carotid artery. If the patient, for whatever reason, had a arterial carotid artery puncture within 7 days, then that would be a contraindication. Obviously, CEA would be a contraindication. And then blood pressure and labs also included. Oh, sorry. Yes, that's the other part. If you see an infarction that is over 1/3 of the MCA, complete infarction, hypodense tissue, that's also a contraindication because it's a completed stroke.
Is the history of previous intracranial hemorrhage ever in their lifetime?
Yes. Yes.
So it doesn't matter if it's active.
If they ever have a bleed, they're not going to give TPA. The history of aneurysm is untreated aneurysm. If the patient has a clipped or coiled aneurysm that was non-ruptured aneurysm, then it's not a contraindication. If it was ruptured, then it is a contraindication. Same for AVM. If it was treated, it's not there anymore. And and it was not a ruptured AVM, then it's not a contraindication anymore. And these are user preference. The more aggressive your neurologist, the more TPA is going to give. If they're not aggressive and they're looking for reasons not to give it, then they're going to tell you it's not a candidate. But the guidelines specifically say that it's not a contraindication. If the aneurysm is treated and it was an unruptured, it's not there anymore. And the same goes for the size of the aneurysm, which I'll talk about later. So your CT, you're going to be looking for subarachnoid, any kind of hemorrhage, any intracranial neoplasm, and then you have to specify if it's, let's assume you're just doing a CT without. So you just specify if it's intraaxial or extraaxial, because extraaxial tumors are not a contraindication for TPA, meaning a meningioma is not a contraindication, pituitary adenoma is not a contraindication. Again, it depends on your neurologist if they do want to give it or they don't want to give it. You look for your dense MCA, your dense basilar artery, your dot sign on the MCA, complete infarction, which is that 1/3 of the MCA territory, and lastly, you look at your aspects. So, non-contrast CT scan, you're going to have the first few changes is going to be that sulcal effacement, loss of gray white matter differentiation, and you may or may not have that dense MCA sign. The more edema the patient has, the more sulcal effacement, and that's going to be about less than 67% within 3 hours, but it improves to 82% by 6 hours. So by 6 hours, we usually see very well-defined area of stroke. In the first few hours, the findings are very, very subtle. And that dense MCA sign is about 30%. My experience is more about 30% than 50% of the MCAs. It doesn't mean it's not clotted. So you're going to be looking for a hyperdense fluid in the subarachnoid space. This would be easy to pick up. Maybe a little bit of intraventricular hemorrhage if you have it. Maybe more subtle. But you want to be on the lookout for the subtle signs, not the ones that everyone can see. So a little bit of subarachnoid hemorrhage there. Hyperdense MCA tells you that that MCA is clotted. So if you don't have it, it doesn't mean it's not clotted, but if you do have it, then that we can even not do the CTA. I mean, you do have a thrombosed MCA there. And the sulcal effacement, if you compare the right side with the left side, your sul side, you can see them very well here on the left side, and on the right side, they're already effaced. And if we do nothing, then that patient evolves to a complete MCA stroke. Subarachnoid subdural hemorrhage, obviously you're not looking for this one because no one's going to miss this one. So you're looking for this ones that maybe you have an isodense subdural here. You see it better on the back, but it's the whole hemisphere that has a subdural, or that tiny one there that may be missed. And again, I know you're pushed to do the read on the control booth in the CT, and that's fine, okay? That's not a problem. You do that, you do your best, you say it's clear, and they can start mixing the TPA. You go back and you read it, and you find something, just call them, and they can turn it off, and maybe nothing happens. So don't be afraid to call back with any new findings, and don't be afraid to call it normal right there on the control booth. I mean, most of the cases, if you see it normal there, it'll be like that, and if you miss this little one, you can call back 20 minutes later and then they just turn off the TPA and nothing happens, okay? And I guess that's your evolution after 6 hours. You may see already this, and this would be a third or more than 1/3 of the MCA, so this is one of the contraindications, more than 1/3 of the MCA. Any big vessel can have a hyperdense sign, hyperdense PCA, evolution to PCA stroke, hyperdense basilar artery occlusion, okay? Ask you and the neurologist converge in the control room, always ask them for the symptoms and focus on that side. And then you can go back to PACS and look at the whole thing, but you want to focus on the side of the symptoms when you're right there and trying to make a decision, especially when we go to the CT perfusion, because you'll be the ones that tell the tech if we're going to do it or we're not going to do it.
I also put in the history the symptoms, because many times it says stroke and you have to put there. If you're sitting there and you know the symptoms, just put it there. It will help us when we do the final.
And patient has right side weakness, aphasia, or dysarthria. So you're going to look at your left hemisphere, left MCA and basilar artery, okay? Right side, left side weakness, you look at your right MCA and the basilar artery. Always look at the basilar artery, okay? Doesn't matter what side the symptoms are, because those are very vague and they can include both sides. So MCA on the side that you think is affected and the basilar artery. And your cervical carotid on the side that you think is affected. This is another sign we see sometimes. You look at both sylvian fissures and you see that hyperdense dot there. That's the MCA dot sign, which is an M2 or M3 occlusion.
So, Hugo, can you go back? Look at the basilar artery there. It's also hyperdense. So,
yeah.
Sometimes the vessels are...
Sometimes the vessels are hyperdense.
Can you help us?
I mean, we still get the CTA, and then you'll know if it's actually occluded or not. And depending on how much beam hardening artifact you have, the basilar artery looks hyperdense a lot of the times. But we always get that CTA. That's why we always get that CTA. So we're not basing on this. But if you have this and the CTA, you may want to take a closer look at that area to make sure that it's not occluded. So it's just to help you kind of look more closely to that area, not to make the diagnosis. And again, the tumors, which again can give you stroke-like symptoms. If you just have a non-contrast CT, so you would call this likely a meningioma. It could be a schwannoma. I mean, it's an extra-axial tumor. And then they can decide whether they're going to give TPA or not. If it's intraaxial, then it's a no-no, so they're not giving TPA. But if it's a meningioma, they may or may not give TPA. And then we get to the aspects, which probably about half of you report. So we need to report it more often. And the more often you report it, the more comfortable you're going to be with it. Don't think it's a all or nothing or a like 9 or 10 or 8 or you can give a range. So if you have a 9-ish or a 10-ish or a 8-ish or a 9 to 10 or 8 to 10, that's fine. Doesn't have to be. Our cutoff is 6. So if you say, well, it's 5 to 6, if the patient is 40 years old, I may err on the 6 side and do it. And if it's an 80-year-old, maybe I'll say, well, we're not gonna do it.
So even if it's a normal, sometimes if it's a normal CT, I don't put the aspect. Even if it's a normal CT, you put aspect.
No, if it's because you have the CT and the CTA,
Okay.
and then you have no large vessel occlusion, then you don't need to put the aspects. So it's all for the occlusions. So that aspects, it stands for Alberta Stroke Primarily CT score, so it's not aspect score, it's just aspects. And it's 10 points, and you know it's been validated by several studies, and the cutoff is 6, when we're going to be looking for a focal parenchymal hypodensity or cortical swelling or sulcal effacement with loss of great white matter differentiation, and that'll count as a negative point. So we start with 10, and we start discounting points for each area that is going to be affected. There's 10 territories, and you look at the whole scan, but there's 2 that you have to look at which is the ganglionic level of the basal ganglia, and above that level, the supraganglionic level. At the ganglionic level, you're going to look at the caudate nucleus, the lentiform nucleus, the internal capsule, and the insula, and those are going to be your deep structures. Those four are your deep structures. And then lateral to that, you're going to have your anterior MCA territory, your lateral MCA territory, your posterior MCA territory, and then you just go the cut above, and then you have anterior, lateral, and posterior MCA territories. And those are your M4, 5, and 6. And that gives you your 10 points of the aspects. And if you remember this picture, one at the basal ganglia, one above the basal ganglia, one at the basal ganglia, one above the basal ganglia. Remember it because this is our slab placement for our CT perfusion. This is what we want for CT perfusion. You want this cut and this cut. Okay? You don't want this cut and this cut, or this cut. You want this cut and this cut, or this one and this one. Okay, that's our slab placement. We have one, we want one at the basal ganglia and one above the basal ganglia. And these are some examples. You see MCA, hyperdense MCA here on the left. These are 10 caudate, lentiform, insular, internal capsule, or 4 deep structures, or 3 MCA cortex lateral to that, and or 3 MCA cortex above that. And this patient mostly had a aspects of 10. Maybe if you want to, and you say, well, there's an insular ribbon there, it's loss of the gray-white matter differentiation, you want to give it a 9, that's fine. 9, 10, 9, 10-ish is fine because it's not going to make a lot of difference for the, so don't get caught up in the 9 and 8 or 10. So that, just an idea. So the onset was at 5. This was done 1 hour later, so it's obviously it's not going to show big changes. Okay. Another case, another left MCA, hyperdense MCA, and you can always see, and now you can already see this big hypodensity here, and so in this case we gave M1 insula, lentiform, internal capsule, M4, M5, and M6. And this was a 4, and if you want to give the M4, that's still going to be a 3, so it's not going to make a big difference again. So just give a range. I guess if you give a range of 5 to 7, that would be the one that I had to decide, or we would probably get a CT perfusion and make a more objective decision, right? So this was onset at 5 p.m. The CAT scan was done 7 hours later, so obviously it was completely infarcted. And then if we go and open this, then we get this.
Okay. So even though the CAT scans may be done after the window,
Mm-hmm.
you can still go ahead and give aspects?
After the thrombectomy window?
Yes.
Well, that would be after 24 hours. You don't need to do the aspects after 24 hours because they're not going to get anything done.
Anytime within 24 hours.
And this is another example. Aspects was given a 10. Pretty nice. If you want to say, well, there's some sulcal effacement here, the insula, and maybe M2, you give it at 8, and it still doesn't make a difference. Left MCA occlusion right here. Went to thrombectomy, and then aspects 10 again for after the thrombectomy. So after, some patients will just get very few patients that we cannot get an IV will just get that to assess for thrombolysis right there. And then they'll get them back for the CTA 20 or 30 minutes later once they get the IV. So that's your initial assessment. That's what you want to tell them based on just your CT without. Then we go to the CTA that I would say probably 80% of our stroke patients are getting both at the same time. So you're going to assess for a large vessel occlusion. You want to look at your cervical ICA, intracranial ICA, middle cerebral artery, anterior cerebral artery, and your basilar artery, okay? And that's what you're looking at in the control booth. When you go back, then you can look for your vertebral arteries and everything else. And I'm not including vertebral arteries because a vertebral artery occlusion on one side, if the patient is getting flow from the other side, I'm not going to do that. I'm not going to do anything for that, okay? I'm not going to do anything for a pica. I'm not going to do anything for a PCA stroke unless it's like a very severe PCA stroke, or maybe it's involving the top of the vascular. So you look at the top of the vascular, the basilar artery, ICA, MCA, ACA potentially, but we may not do anything for the ACA. And then once you're back and you're ready to report, you're going to assess for carotid stenosis. Again, aneurysms more than 10 millimeters you should catch on your control booth. And those are the ones that are contraindication.
Quick question on the assessment for carotid stenosis.
Mm-hmm.
There's a neurologist here, I think he's a recent hire. He wanted us to give him a specific or a more defined carotid stenosis percentage. So he wanted us to give him the NASA, using the NASA criteria, but to do that, in order to do that, he wanted us to do the curved reformat. So that takes a lot of time for us to do while we're on call.
No, that's not. You go to the AW and you do it in the AW. It's easy.
But he doesn't want that in the acute
when
setting.
we report it on call, that was my next question. Do we do an estimate of mild, moderate, severe? But he wants an exact percentage.
That's for the internal carotid artery.
Yeah,
Yeah.
so the carotid stenosis.
Yes,
and
but
the
you do
cervi-
that for your report, for your final report.
Yeah.
This is not for your, like for your immediate assessment, your preliminary at 2 in the morning.
Yeah.
You can tell him moderate, severe, and he can, that's what he has to have.
Okay,
I mean,
good.
I'm not gonna, that's not necessary for you to
Yeah,
go to the
that's what I thought.
workstation and do a curve reconstruction
Sure.
and tell him at 2 in the morning that there is an 80%
Yes, but
stenosis.
it's not a core reconstruction. I can. The other day I told you how to do it. It's easy.
So you want us to do that on call or wait till?
If you're checking the angio, you do it in the AW, right? You have the thin slices.
Yeah, you do it on the AW, but I thought only there's a workstation next to Dr. GT's office in which he does the
No, I can teach you how to do it.
reconstruction.
But I don't know, Hugo, this is up to you, whatever you want, but in the preliminary, maybe you don't have to do the stenosis, but when you are dictating, it's...
So when you're dictating, yes, but preliminary you don't need to do that.
Okay.
I will show you how to do this.
Again, aneurysms, AVMs, pseudo-occlusion, and moya moya, it's another big one that you should try to pick up because that's another contraindication for both thrombectomy and thrombolysis. So you scroll through your images and try to look at all the 4 vessels. You're going to pick up on a lot of atherosclerotic disease. Left side, you see there's a severe carotid stenosis, and you can say there's a severe carotid stenosis. But then it goes up, and then it starts to fade again. So you're probably, at this point, you're going to be thinking there's no outflow. So now you can see there's a clot in the cavernous and supraclinoid segment of the ICA, and the whole MCA is also gone there. So there's no MCA there. So that was easy. So that's where you want to look, and then you go back and look at your basilar artery, and then your basilar artery is open, and your left MCA is open. And then you look at your reconstructions. But this is what you're going to be scrolling kind of quick in the control room, because you're going to be more engaged, because at this moment then you're going to say, let's do a CT perfusion, okay? and you can add the order in, or you can have neurology add the order in. But if this was completely normal, then you would say no CT perfusion, because we're not going to radiate every single patient with the CT perfusion. So that's why you're going to have to hone in on this CTA and try to decide if there's an occlusion or not. And you can look at your reconstructions real quick if the tech does them real quick, and just see if you have that MCA occlusion there. If they don't, then you're going to be on your own. But they're pretty correlate very well with the angiograms, and this is the post-thrombectomy angiogram. Aneurysms, I mean, this one that anyone can pick up, that's the one you're going to be looking for, okay? Not the 3 millimeter, 2 millimeter aneurysm. Not in the control booth. And again, AVMs. If you catch them, just tell them. Why the 10 millimeter? Because even though the global contraindications say aneurysm, there is a description, and they recommend that only aneurysms more than 10 are excluded. But again, that's going to be up to neurology. If you tell them there's a 2 millimeter aneurysm and they don't want to do it, then they'll just say, oh, there's an aneurysm. If you go to comprehensive centers, they'll give TPA to almost everyone. Pseudo-occlusion, this is just something to be aware of. That's going to be one of the pitfalls of CTA, and it's going to mimic a dissection, like a flame-shaped type of occlusion. And that's going to be because you have a standing column of blood here that doesn't allow the contrast to go up. So every time you have a clot that is occluding proximal to the ophthalmic artery, then you're going to have this standing column of blood because there's no outflow. That blood, there's no way for that, nowhere for that blood to go. So because your ICA is full of blood, the contrast will not go up on a single phase CTA. If you did a delay exam, then you may see that contrast starting to go up. So this is not a true occlusion. And a lot of times we go in thinking it's an occlusion, and our catheter just breezes through this, and that's just blood. And then the clot is actually at the ophthalmic segment. And that's just something to be aware of. So this would be called dissection versus pseudo-occlusion. It may well be a dissection. There's no way, with a single phase CTA, there's no way for you to tell.
So for us, it's a differential.
For you, it's a differential, dissection versus pseudo-occlusion. But it's still an LBO. I mean, it's still occluded.
Earlier, you said a pseudo-occlusion is a contraindication to TPA?
No, an occlusion of the ICA is a 0% recanalization rate. An occlusion, not contraindication to TPA. Did I say an occlusion was a
I thought it was listed
contraindication?
on one of the contraindication pages.
And the other one that you want to look for is this like fussy pattern of deep vessels in the MCA territory compared to an area that is, completely devoid of vessels. So this would be, you see this puff of smoke pattern, which is the moya pattern of a stroke patient. Patient would present like a stroke, like an LVO, maybe even severe. But if you notice this, then you should call it moya. Okay? And now we have something to be more objective. So you can do a CT perfusion after. You send the patient back, and then you pick up on this and this. Oh, just, you know what, let's bring it back and do the CTP. Okay? So this is an ICA-T occlusion. There's no fussy pattern. There's absolutely no contrast. and the clot is included the proximal M1, the proximal A1, the proximal M1, and the ICA. Okay? So, thrombus occlusion, moya moya. Occlusion to the MCA is occluded, but there's all this cluster of blood vessels around it. Moya moya, thrombus occlusion, acute occlusion, moya moya. There's no MCA, that's for sure, but there's all these perforating vessels that are hypertrophied. So any stroke A within 4.5 hours will continue to get just the CT and the CTA, and then your aspects. So anyone within 4.5 hours will just go with the aspects for thrombectomy. If you have a questionable occlusion, just obtain the CTP, okay? If you have a questionable acute or chronic occlusion, you can obtain the CT perfusion. If you have an ICA, cervical ICA occlusion, and then your MCAs are open, and that's a questionable acute versus chronic, you can go ahead and get the CTP, okay? Because that'll give us more information. Like I said, otherwise, for those patients within 4.5 hours, we'll just do the aspects and the LVO, and we'll not do the CTP. If you want to order the CTP, just order it for a stroke A. Okay, you have that power to make that decision. If you're back in PACS and you say, oh, maybe there's a stenosis at the M2 or an occlusion at the M2, just bring the patient back. I mean, now we can be more objective. So the CT perfusion will be used for every single stroke B patient from 4.5 to 24 hours that we suspect has an LVO. It's a first pass tracer method. After the injection of contrast, we're going to observe the dynamic flow of that contrast going in and out of the brain, and it's very widespread available, more than MRI. I tried doing an MRI Saturday, and it took me 2 hours to get the patient, 1 hour to get the tech here, 1 hour to 30 minutes to get the patient down to MR, another hour to do the MRI. So we're not doing MRIs for acute patients. Okay, so CT, very specific cases that we'll talk at the end. CT it's going to show the physiologic process of blood volume, blood flow, and it's going to widen our reperfusion window, okay? So these are what you may have read about, the cerebral blood flow, cerebral blood volume, mean transit time, Tmax, and that's what they mean. The matched perfusion between blood volume and mean transit time corresponds to the cord infarct, or matched perfusion mismatch with the prolonged MTT. That's what we used to do in our all CTP. So some of you may have done all CTPs, and then we obtained the CTP, then you went to the workstation to get these ugly images, and it took you 30 minutes to get that, and we never used them. So we stopped using that. But this is what you saw. You saw decreased blood flow, normal volume, blood volume, and increased mean transit time. So there was a mismatch between the transit time and the blood volume, or the blood flow and the blood volume. So this was salvageable tissue. This was our penumbra. Or you got this, decreased blood flow, decreased volume, increased transit time. So this was a matched defect, and this was a core infarct, and we did not take the patient. CT perfusion before intravenous TPA, big increase in mean transit time, decrease in blood volume, decrease in blood flow. After TPA, small basal ganglia stroke, and again, normalization of the blood volume and blood flow and transit time. So, but it took us a long time to do this. So there was a human element to do this that was not, it's not good for our acute ischemic strokes, because we're trying to do this very fast. So we finally got this rapid software. So you'll be getting these emails too, but you'll get you'll actually get the images faster in PACS than the email. So your PACS rapid maps will be there in 2 minutes after you obtain your CT perfusion. The email comes in about after 4 minutes. So it takes additional 2 minutes to go through the net and get it in your phone. But you'll get that in your phone. And those are based on the, our extended windows are based on the diffuse 3 parameters, which is a core less than 70 cc's, a core to Tmax more than 6 of 1.8. That's the mismatch ratio of more than 1.8, and more than 15 cc's of absolute salvageable penumbra. These diffuse 3 parameters are what we're going to use to define what patients are going to be candidates. The Dawn parameters, they just use clinical plus volume of core and 2 subgroups of H, and we're not going to use this, so we're going to use this. The threshold of less than, the threshold of the ischemic core for cerebral blood flow is 30%. So less than 30% blood flow, it's the ischemic core. Okay? A threshold of 38% is going to predict the volume very well compared to DWI, but it overcalls a little bit of those. So 30% will not overcall. That means that that particular tissue of brain has less than 70% of blood flow. Okay? So those are going to be our parameters. Those are what you're going to be looking at. You're going to be looking at these maps. You always look at your normal CT. You have a CT perfusion. In pink, that's the core of less than 30% cerebral blood flow. And in green, you're going to see your Tmax more than 6 seconds. So just eyeballing it, you know there's a big penumbra here. But you're going to be given the numbers, the exact numbers in those rapid maps. So if we do nothing and we just scan the patient again at 8 hours, we can see the core keeps getting bigger, penumbra is mostly the same, and then after 24 hours, we see a big defect in the non-contrast CT, and that it matches the penumbra that we had. Has anyone seen the rapid training videos? Some of you have? Okay. So then you know that rapid has, the software has a rule that when the tissue is very hypodense, approaching the CSF, it'll not pick it up, okay? And that's as to not pick up chronic strokes. So that's why you're not seeing it here pink, because it's already so hypodense that it just rules it out as an old stroke. And then your penumbra is still the same, and it matches the core. So that's if you don't do anything. Or if we get reperfusion, again, a small core, big penumbra, you get reperfusion, and now everything is normalized, and you see that little core in the non-contrast CT matches that in the cerebral blood flow. And if we see this normal brain, big core matching the penumbra, even if we get reperfusion, you still get that big MCA stroke. So this is what you're going to be looking at. So you're going to look at that CTA, decide if you have a CT, a large vessel occlusion, and if you do, then you tell the tech to go ahead and do the CT perfusion. This is your slabs placement, okay? So we have a 64 slice scanner, and that requires that we do 2 CT perfusions, so 2 slabs. One of these is the bottom slab and the top slab. So we want to place them. You're going to look at your planum sphenoidal or your orbital frontal plate, and you're going to put it about 1 centimeter above your first slab, okay? Not next to it, because if we put it next to it, we're going to have this. Well, hopefully we'll get a 250 or 320 scanner, and then we can do just 1 slab and then you don't have to tell anyone where to put the slab because it'll be the whole brain. So that would be your 250 scanner. 320 will get everything. So if you do that first lab next to the planum, you'll get this. So you get the basal cisterns. We don't get any basal ganglia or a little bit of the thalamus. This rapid will not process. Okay, so our bottom slab has to be at the basal ganglia, and the top slab you want it above the basal ganglia. Okay, so these are the two that you wanna get, and those are equivalent to the ones you look for your aspects. All right. For some reason, there's a lot of CT head perfusion things in the text CT there, and a lot of pre-programmed scans. They have to choose CT perfusion rapid. There's like 3 of them, and then one of them says CT perfusion rapid. That's the right one. Okay. You do your CT and your CTA first. You pause, review the CTA. If you identify that LVO or you're not sure, then you just proceed with the CT perfusion. The injector will have 70 cc's of contrast plus 40 cc's of saline push for the CTA, and then a hold. And then you'll have 40 cc's of contrast and 40 cc saline push for each slab of CTP. And there's a hold between each slab of CTP. CTP, as soon as it's obtained, it'll automatically send to rapid, and you'll have your images in the PACS in 2 minutes and the email summary in 4 minutes, okay? And these are the parameters that you want to look at. So cerebral blood flow less than 30%, which is the tissue that's irreversibly damaged. At time to maximum residue function of more than 6, that is the tissue that is likely to progress to infarct. At T max more than 10 is something that's going to progress very rapidly to stroke. And at T max more than 4 is benign oligoemia, or some tissue that is not going to likely to progress to stroke. And this is what we want to see in chronic occlusions. So if you do the CTP for a chronic occlusion and all you have is this T max more than 4 and nothing more than 6 and 10, then it's likely to be a chronic occlusion. Look at these movement maps. These are you're going to get this in the rapid. If you see this, you know you're going to get a bad quality perfusion that you may or may not trust. This is a lot of movement. Each of these spikes is a lot of movement. And then you get this also. Rapid processing finished successfully, data quality warning, insufficient bolus, or patient motion, etc. Okay? So it gives you warnings to kind of be aware that this may have happened. And then you look at your maps, and if they look like this, it's probably not good.
Sir,
Which is what happened with this one.
reacquire a slab if they've got a lot of movement, or?
A lot of these patients are going to move because they're not they're not following commands, so there's no point of reacquiring. And if it's a little movement, rapid can handle that. But when they're moving a lot, you're not going to make them still. So we'll just go with
The each slab acquisition.
it's 60 seconds for each one. So it'll be you'll hear that radiation going for 60 seconds for each of them. So this patient, always trust also your non-contrast CT. Okay, so this patient had complete sulcal effacement, hypodense MCA territory. We obtained this that showed this little core with this big penumbra and with a lot of but this is that patient with a lot of motion. Okay. So we took that patient and reperfused, and patient ended up having the same MCA stroke, okay? Look at your arterial input flow and venous outflow. They should look like this, okay? you're gonna get this, so usually your arterial input flow is gonna be in the A2, and your venous outflow is gonna be in the superior sagittal sinus. This is that patient. You see where that arterial input is? That's the internal cerebral vein. And then the outflow it's in the superior sagittal sinus, but the arterial input is nowhere near the A2 or the MCA. Okay, so that was a bad CT perfusion, nothing to. So look at those warnings, look at this, make sure it's a good CTP. Something like this, okay? So this is what you're gonna get. It's gonna give you your less than 30% volume, Tmax volume, your mismatch volume, and your mismatch ratio, okay? For the two slabs. So in this bottom slab, this is one patient, this is another patient. So this is a matched core. Mismatch ratio 1.2, so it doesn't fit the parameters. Salvageable tissue 6 cc, so it doesn't fit the more than 30%. And the core is less than 70 here, but still it doesn't fit it has to fit all three parameters, okay? So less than 70, mismatch 1.8, and more than 15 cc of salvageable tissue. In this case, core was 10, Tmax more than 6 is 65, which is not true because it's getting this motion from the left side, okay? But if you eyeball it, it's still much bigger. This side is much bigger than this. So this is not correct, but still you get this nice green map that tells you that it's about twice the pink map. And then you get this column view. This patient has a big MCA stroke, decreased blood volume, decreased blood flow, increased map transit time, and increased Tmax. But it's already dead tissue, so trust your non-contrast CT. This is your normal movement map, or this is what you want to get in your movement maps, just a little bit, I mean nothing. And this is your normal input-outflow map that you want to get for a patient like this. You're going to get a lot of ranges. We're just focusing on the 30%, okay? This is just so we get an idea of what's going to end up infarcting faster and what's going to end up lasting a little longer, but the 30% is our blood volume, and you get it in different colors. So here, 30% green is what we're looking at. Our Tmax also has different volumes. We're going to use more than 4 for a chronic occlusions and more than 6 for a penumbra. More than 10 will probably infarct very rapidly. You'll get this cerebral blood volume map that we're not going to use, but you'll have it there. Look at this. This is what we need to look, okay? And it gives you all the information we need for those diffuse 3 parameters right here. MRI, we're going to use it in just special cases or for follow-ups. It's beautiful. I'll show you the pictures. It's much, much better than the CTP that just gets 2 slabs, but it takes a lot of time. We can get the whole brain. Again, this is a patient IC occlusion over 24 hours. So patient had an IC occlusion for 48 hours, close to 72. So that's why I went with the MR. We were over the 24, and I didn't know if I want to do the case or not. So nice movement maps. You get this DWI volume, which was 0. Patient only had these punctate infarcts on the right MCA. Patient had a CEA 3 days before, occluded within 24 hours, and then 48 hours later was transferred for potentially thrombectomy. We'll get these perfusion maps of the whole brain. Now you'll get from the posterior fossa all the way to the convexity. So we can see in green the area that is Tmax more than 6, but you get all the volume here. Tmax more than 6 is only 38 cc's, and we can see that this patient has about 110 cc's of Tmax more than 4, which will probably never progress to complete stroke. But 38 cc's are still at risk. So I decided to take this patient to thrombectomy despite being like almost 3 days. And if you see, you get this column view with the diffusion and the blood flow and blood volume, mean transit time, and Tmax. And you can see here the big MCA perfusion defect on the right side. ACA was probably getting collateral from the ACOM. We did the recanalization, and I did an MRI again just for educational purposes 24 hours later. Diffusion, again, 0 cc's of stroke because it doesn't pick up these little strokes. Same little strokes as before, no new punctate strokes. All the Tmax, all the penumbra went to 0, so there was no longer hypoperfused territory. And you can see the post-recanalization column compared with the pre. That big defect is gone. So this helped drive that decision, and it'll help drive the decision for chronic occlusions too. And you're gonna now be asked to do Diamos tests, and we're gonna be I was asked yesterday to do one. So the Diamox test will be ordered for chronic occlusions and moya moya. So we're gonna do a baseline MR, and you send it to Rapid. Then you need to push 1,000 milligrams of IV acetazolamide, and that's a bolus over 5 minutes. And then we repeat the MR perfusion 10 to 15 minutes and send it to Rapid, okay? There's just a few contraindications to acetazolamide with hypersensitivity to sulfonamides, electrolyte disturbances, kidney or liver disease, which kidney disease will probably prevent the patient from having an MR perfusion because of the contrast. So same contraindication, adrenocortical insufficiency, and glaucoma. Okay, it's going to be we're going to compare that baseline blood flow before the Diamox injection to after Diamox injection. In normal patients, there should be an increase in blood flow of about 30 to 60%, because what Diamox does is it vasodilates those intracranial vessels. So if the patient has a chronic occlusion, and they can still have some reserve, those will vasodilate and you'll have an increased perfusion. If the patient is at the maximum vasodilation, what's going to happen is the blood flow will decrease, and then that patient would be deemed a candidate for bypass. So that's why we want to do this, and that's why they're asking to do this Diamox test. So you can call me whenever you get this order in. I'm tracking that patient that was ordered, so we'll see when it's scheduled, and we can do that in the MR the first time. But then the techs should know what to do. And, it's just the IV push of Diamox, and the patient will have to sit on the scanner for 10 or 15 minutes and then rescan again. And that's about it. And then you're just going to compare, and your Rapid will give you volumes, so you'll compare your volume before and your volume after, and see if there's an increase in blood flow. So the possible scenario that you're going to have is a stroke A. Keep doing what you're doing, your CT, CTA, and report your aspects. And your stroke B, CT, CTA. If you identify an LVO, proceed with the CTP. Or if you have any doubts, just proceed with the CTP. If you have a transfer with no CTA, we'll do this again. If the patient arrives within 4.5 hours, we'll do CT, CTA. If it's after 4.5, we'll do CTA, CTP. If the transfer is a confirmed LVO, we're only going to do the CTP because that's going to include the non-contrast CT scan, okay? And this is obviously for the ones that are not from Wills-Knighton. If you identify a vascular occlusion on your CTA, don't do a CTP because it's not for that. It's not for the posterior circulation. So
all this information from my residents? Where do they have to take
Here.
a picture with a phone or?
Yeah, I can send it to you,
do I
and we're
share a
just,
call?
yeah, this is on the protocols that we're changing, we're getting, but you can get this
So
from here.
Are you sending emails?
I'll send you this slide to everyone, so you can know, but this will change in the protocols. It'll be in the protocols, but I'll send this. Basilar occlusions, no CTP, is not good for posterior fossa. Again, if you have an initial negative read and then not sure, bring it back. I'm gonna ask for a MR perfusion in basilar occlusions that are more than 12 hours old, and MCA or ICA occlusions that are over 24 hours. That's when we would probably order an MR perfusion. And the Diamox test for chronic occlusions, which is not an acute setting. Okay. But the main point is now we have a tool that can allow us to be more objective. So we're not like, well, maybe it is, maybe it is not, just order it. And you have the power to order it, just put the order in, okay? And this is the same thing. So remember that motion artifact will give you a poor map, poor injection will give you a poor map. So check those arterial input flow and venous outflow. Report your volume of core less than 30%, your penumbra, Tmax more than 6%, your mismatch ratio, and your overall salvageable tissue. And that's what we're going to use, the 1.8. For patients, we get some 40-year-olds and 30-year-olds with stroke, so we may be a little more lax on those with a mismatch less than 1.5. But we'll decide that in the next following weeks. And always trust. I mean, if you see this, and just don't go to your CT perfusion because there's no need. You can do it in the next few weeks just to practice. Even if your stroke case, if you have an LVO and you want to practice, just order a CT perfusion and see how it looks. We officially will rolling out on October. So this September is for you to order as many as you want and just see how they come out and look at the maps and all that. And the protocols will change October 1st, and that's when we're going to try to just do them for the ones that really need them. Okay.
Can you email the presentation to Elisa or she can send it to the
So go back to that iRapid, training rapid, and look at those. Actually, this is a video. So yeah, those, you don't need a CTP for that, except in September.
There you go. Excellent.
Go there. It'll take you 15 minutes to look at all 4 videos.
Based on occlusion, why are we doing it for the MRI but not for the CT? What was the purpose behind it?
The CT doesn't work for posterior fossa. And then after 12 hours, the timing, I mean, there may already be a big brainstem stroke, so I want to make sure if I'm going to do the thrombectomy, there's something to say.
Thank you.